Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I'd like to welcome you to our provincial rounds, development of the new Ontario Perinatal Record. A question and answer period will occur at the end of the presentation. Please type your questions into the chat box in the lower left-hand corner of your screen, and feel free to enter a question at any time during the presentation. As you have heard, these rounds are being recorded and will be posted to the Born Ontario website. Dr. Anne Berenger and Dr. Anne Sprague are co-chairing the working group tasked with creating the new Ontario Perinatal Record, and we're very pleased to have both of them presenting today. Anne Berenger is a family physician and an associate professor of the University of Toronto in the Department of Family and Community Medicine. She practices intrapartum maternity care at Mount Sinai Hospital. Anne Sprague is the scientific manager of Born Ontario and is responsible for leading the team that works hard to turn the Born data into information and knowledge to support clinicians and healthcare policy makers with their work. PCMCH has provided a great deal of support to the creation of the new Ontario Perinatal Record. Anne Buccarelli is also on the call. Anna is a PCMCH Senior Program Manager and the PCMCH lead for this project. So now I'll turn it over to our presenters. Welcome.
Thank you, Kathy. It's Anne Sprague, and I'm going to start off the presentation. I will do a few slides, and then I will turn it over to Anne Berenger, who will actually show you the draft of the new perinatal record, and we'll all be available to answer your questions at the end if need be. So I'm just going to take us now to the slides and try and advance the slides here. Val, mine, oh, here we go. All right. So just showing you the title slide, and then the next slide. They are slow today. Sorry, loading. Val, can you try? And mine won't advance.
I can see the second slide, Anne.
Okay. I can't.
So you want to go to the third now, right?
I wanted to start with the learning objectives, but my slides aren't advancing on my screen, so I can't see. There we go. Just switched now. All right. So the objectives for today's presentation, we're going to describe the process for developing the new Ontario Perinatal Record. We're going to describe new items and screening tools that are embedded in the new revised record. And we'll outline a little bit about what we've figured out to date in terms of implementing the new record and the accompanying guide that will go with it. Next slide, Val, please. Yeah, mine just isn't advancing. There we go. All right. So just to start with a little bit of history, the Ontario Antenatal Record was originally developed and housed within the Ontario Medical Association. And they had a committee structure set up to be able to look at this record on an ongoing basis and do some updates. However, the last update was in 2005, and as any of you know who work in the clinical area, there's been a lot of changes in clinical practice since then. And the OMA at this point in time didn't have any ongoing resources or plans for subsequent updates. We also know that in the landscape of healthcare, electronic medical records, or EMRs, are an important part of how we document care and how we are able to extract information. And it's important for provincial forms to have a home within EMRs, but there was no plan for electronic functionality. In 2012-2013, Born undertook a pilot project with 2 EMR vendors in Ontario to see if we could take that what was a traditionally paper-based record for the OAR and turn that into a true electronic form. We knew a lot of people were using more of a fillable PDF, but really to have an electronic functionality for the OAR at that time. And that pilot was very successful working with 2 vendors. However, what was out of scope during that project was a content update. And when we did the evaluation of the project, people said, yeah, we like the functionality, but really it's time to update that form. Next slide, please. So The vision for the future is that the new form will be housed at PCMCH and a version control will be maintained there. And so this pilot project that we've done now, or this project to update the form, is truly a partnership between Born Ontario, the Provincial Council for Maternal Child Health, together with some other partners that have come on and are important in this in terms of our midwifery partners through the AOM, and continuing on having the OMA involved in this as well. And then there were a number of other people who took part in the process. And long term, we hope that that data that is sitting in the OAR, now to be renamed, but I'll talk about that in a minute, will actually be able to flow through to the Born Registry and pre-populate some of the record in the BIS, so that takes the burden of data entry away and takes the source of truth closer to the time for some of this care that's occurring back in the early antenatal period. Next slide, please. So the purpose of our working group when we came together was to review and update the current OAR, think about the postpartum record and how it was used in the past and how it could be used in the future, and develop a user guide that would help people, and especially learners, be able to use this record. And it was a partnership, as I mentioned, between all of these various agencies. Next slide. So these are the working group members. You can see Dr. Ann Berenger and myself as co-chairs. Dr. Deborah Boyce, who's a family physician in Peterborough. Dr. Doug Cochin, who's an obstetrician at the Queen's Vic Carleton in Ottawa and also has quite an interest in electronic health records. Dr. Barb DeVrier, who's an obstetrician and maternal fetal medicine specialist at London Health Sciences Centre. Dr. Jessica D., who's an obstetrician at the Ottawa Hospital. Mrs. Dara Laxer, who is a senior policy analyst at the Ontario Medical Association. Dr. Stan Lofsky was a family physician involved with North York General Hospital. Matuska Sheedy in health promotion at Best Start. Bill Mundell, an obstetrician and maternal fetal medicine specialist in Windsor. Claudia Steffler, a nurse practitioner in a maternity care center in Hamilton. Julie Toole, who's with the Association of Ontario Midwives as a risk analyst. And then our important partners and huge resources at PCMCH, Doreen Day, who was recently gone on maternity leave, and Anna, who was introduced at the very beginning, and those folks helped us. Next slide, please. I'm hearing a fair bit of background noise. I'm hoping that maybe people could mute their lines if you're not muted.
And just for the moderator, *1 on your phone will mute your line.
Yeah.
And unmute as well.
And because our working group, we knew that, we didn't have we had a very bright group of people who were highly committed, but we knew we didn't have all the expertise we needed. And so we we asked for volunteers from consultants who helped us along the way. And you can see those people listed here, but basically we needed help to figure out a little bit more about what to do about mental health, and we had Dr. Cindy Lee Dennis and Dr. Dawn Kingston who provided advice and direction on that. Definitely screening had changed since 2005 drastically, and Dr. Nan Oken helped with that. We had some folks from Dr. Ann McLeod in medicine and hematology, Dr. Mark Uden from OBGYN and infectious diseases, Shelley Dugan also with screening, Dr. Lisa Graves, a family med and substance abuse person with a lot of knowledge in that area, Dr. Denise Fagg we consulted about specifically about diabetes and some other endocrinology aspects. And recently we're just getting ready to talk to Dr. Peter Selby in regards to smoking specifically and some other substance issues. So that's really the team that helped us get to where we are today. Next slide, please. So in order to know what to do with the OAR, we actually went out to seek help from stakeholders. And we asked them what the 3 to 5 changes you'd really like to see in terms of content, and that's what we were going to tackle first, and then functionality. If it truly was an EMR version, and to date we still have to have both a paper version and an EMR version because there's still people using paper. But what would be the most important content and functionality updates? Next slide, please. We actually got quite a few responses, more than 350 responses, and it was sent to all the people who use the form: obstetricians, family physicians, midwives, nurse practitioners, and nurses. But it was also disseminated around the community, and we got feedback from practitioners in mental health, public health, genetics, and pediatrics, as well as all important parts of the care team who would be able to add perspective. Next slide, please. And so the highlights from that survey said, please update the lab and ultrasound sections, and some very specific things that they wanted to see. Add some more demographics. Please add more detail about alcohol and drug use. It's important. More detail about breastfeeding. More psychosocial information, especially related to social determinants of health. As we know that BMI and weight gain and healthy active living is important. More information on that. And there was questions about the relevance of the physical exam that Anne will address later. Next slide. So our group took all that information. So we reviewed the survey results. We consulted current guidelines and best evidence about, prenatal care. What was effective, what wasn't effective, what should be included, et cetera, from the literature. We did a large consultation with the other provincial and national antenatal records, and we actually looked even in other countries as well at what they were collecting and how they did it. And then, as I mentioned, you did do some expert consultation where required. So that was our process for what we got to. Next slide, please. And so when we sat down to figure out what we could change and what we couldn't change, we did have some decision-making criteria. And when considering changes to the clinical content or data elements, we asked ourselves every time, is what we're proposing evidence-informed clinical care? Is it or should it be part of a standard care pathway? Remember that the Ontario record is really to meet the needs of everybody. And we know that there's women who have particular risk factors or circumstances in their life that make their care quite different. But in fact, this record is supposed to be the jumping off point for everybody. Does it contribute to patient safety? So would the data, make a positive impact on patient safety? And would it have an impact on population health? So those are sort of the decision-making criteria that we did. And we haven't quite got to functionality yet. We're working on it now. But basically, we were asking ourselves, does it have the potential to facilitate care? Is it user-friendly? Does it matter in terms of flow and accessibility, the ability to use it? Does it facilitate information flow between care providers? And that's really an important thing with the way that women sometimes move around in the province in terms of prenatal care patterns, et cetera, and with risk. And are the data elements in alignment with those of born? So if we want that data to eventually flow into the born information system, we want the terminology and mapping to be similar. And finally, is the requested change technically feasible? And I guess we would probably add there as we tackle this more, in terms of cost, what will it cost to do that? So we're getting to that point now. Next slide, please. And so now, note the name change. We moved from the Ontario Antenatal Record to the Ontario Perinatal Record. So that's the requested name change to this, and you'll see why as Anne goes through the content. It is not yet final, and this is a project of both PCMCH and Born, and so it has to go to those agencies once we finish it for their final consideration and approval. However, in the last month and a half, it has gone out for review by members of the Ontario Medical Association. Certainly the sections in the OMA have had a chance to review it. The College of Family Physicians, the Canadian Medical Protective Association, the Association of Ontario Midwives, HIROC, the Health Insurance Reciprocal, all seeking feedback. We've received over 120 individuals and organizations' feedback, which we're 3/4 through the way now of reviewing and incorporating what we can do for that. And as I mentioned, the graphic layout for the paper version still needs work. So what you see here shortly isn't what you get. We need expert consultation with graphic designers and we have a big decision to make in terms of the length of this form. So that's a caution as we go through the next part. Next slide, please. And so this is my slide to say, are you excited to, what you're going to see? And that's really my cue to hand over to Anne Berenger, who's going to go through the content.
Thanks, Anne. I'm excited. I hope everybody else is. Unfortunately, I don't have an arrow that you can see, so we'll try to leave the slides on long enough for you to see some of the changes. Our general principle, though, has been to try not to change what we know and love, but to only add things where we really think that they're going to make a difference in care. So as you noted, as Anne noted, there was a request to update demographic information. So you will see here, under the usual name and postal code, you'll see contact, preferred, and alternate, and whether you can leave a message. So now we can catch up with the times and put email addresses, cell phone numbers, and whether those are secure for a message. Beside language, you'll see interpreter required, because that's really important to know. And then right underneath that, you'll see whether the woman has a disability that requires accommodation. Again, important for care. For our midwife colleagues, plan place of birth. Is she planning a home birth, a hospital birth? Which hospital, if somebody has more of the privileges in more than one institution? And finally, clarity around who is going to be looking after the baby, both in hospital and in the community. Next slide, please. Again, this looks quite familiar to those of you who use the form. You will see some additions, though. So first of all, we've added assisted reproduction to the basic pregnancy information because it's so common now. And you'll see we added also the ART dates to the dating method so that the date of the embryo transfer can drive the estimation of the expected date of birth. We also have a bit more information about the past obstetrical history in terms of gravida, GTP-LS, and also more information about the babies, where they breastfed and the duration, what is their current health. Next slide, please. In this category, there are a few minor changes, but not too much. You'll see that we've separated gynae and breast, and in fact added whether they've had uterine or cervical procedures, again, which could impact their both pregnancy and intrapartum care. We have added a couple of food questions, and particularly whether the access or there's quality issue in food. So not just are they able to have enough calcium, and were they on folic acid, which is from the old perinatal record, pardon me, but does poverty, for example, affect their ability to eat nutritiously, and which again has an impact on the pregnancy and is something that the care provider needs to know and can assist with. I think next slide, please. Okay, you'll see a lot of changes on this page. And again, just to reiterate what Anne said, this is not the final version in terms of how it's going to look or how crowded it's going to be. This is just for content. So you'll see that we have just some more specific infectious disease questions. But underneath that is just a much more fulsome mental health history. So with specific questions which are targeting depression, anxiety, and other mental health issues. Because we know that, in fact, prenatal stress, anxiety, depression affect up to 30% of pregnant women. And there is evidence that those conditions affect not just the maternal mental health, but also the baby and child outcomes. And there is now emerging evidence, in fact, that intervening prenatally can actually improve maternal prenatal mental health and also decrease the incidence of postpartum depression, which in turn, of course, affects neonatal and child development. So there have been recommendations from several international organizations to do routine screening of mental health issues in pregnancy. I'm going to explain a little bit more about how we do this when we get to our third page, which has some of these scoring systems. But just to point out that there is a scoring system both for anxiety, depression, and also for alcohol consumption, if that's relevant for this particular woman. You'll also see No, that's next. I think that's all that I'll identify for this page. Yeah, next slide, please. Here's an update of the genetic history, and we based this way of questioning on the Alberta Hereditary Ethnic Risk Assessment. We had a lot of discussion about this, and hope that this is going to be a more useful way of thinking about these hereditary diseases. You'll also notice at the very bottom a question about consanguinity, which is more and more common in many of our new Canadians, and of course has genetic implications. Next slide, please. Okay, on this page you'll see the physical and the initial lab tests. The physical exam, we put just as a at the top there's an exam as indicated, basically giving the clinician kind of permission to circle or identify the elements of the physical exam that they did, rather than recommending that every pregnant woman have a complete head-to-toe exam, because there really isn't a lot of evidence for that. And you'll notice, again, this was one of the items that was brought up in our survey of stakeholders. If you look at the initial labs, they look very familiar, and not much has really changed there, but we do have a whole separate section now where people can write labs they may want to do in special circumstances. And again, this addresses some of the requests from our stakeholder survey, but also for those of you who practice prenatal care, you'll recognize that many of these now have become quite topical for many of our women. And so there's a lot of debate, for example, about routine TSH screening, diabetes screening for women who have risk factors for diabetes, electrophoresis or HPLC for women at risk of thalassemia. So just more room to identify which tests are needed in this particular pregnancy and to document the results. There's also, and you can't see this on this slide, but on the OPR1, on the first page, there is a good-sized box where you can do open comments on and follow up any abnormalities. So if there's an abnormality in the history, you can describe what that was for future care. Okay, next slide, please. So this is page 2 of the perinatal record. Again, this section looks quite familiar. So many of the sort of demographic features will just carry on, and in the electronic version be auto-populated from page 1. You'll see that on the left-hand side in the middle section, it's a problem list. We used to call that risk factors, but we thought that that was actually too narrow. Problem list encompasses a much wider range of issues that you might want to address in this pregnancy. So it's not just specific pregnancy risk factors. It may be psychosocial problems. It may be problems of poverty. It may be non-pregnancy related other medical issues. And then the hope is that when you identify those problems, both in the first prenatal visit but in any subsequent visits, that people will document in that list and keep that really up to date, because that is the key to sort of keeping the prenatal care appropriate to the woman as she develops risks. And it also gives you opportunity to write on the right-hand side of that what your plan of management is, what medications you're using, whether you've gotten a consult, what needs follow-up after the delivery, that kind of thing. And then you'll see in the bottom of that section, low-dose ASA indicated. So that's a reminder, because again, it's a new and an emerging part of prenatal care to identify women who are at risk of disorders of poor placentation, so IUGR, previous IUGR or stillbirth, or women with hypertension or history of PET or the older gravida. And again, we found that was something that people were missing, so this is a reminder to think about that and indicate whether you're using that in this woman. And finally, we've also extended the immunoprophylaxis section, again in response to our stakeholders, but also just according to practice. So there's now room to document whether influenza vaccine was discussed or received or declined, discuss pertussis vaccine, and then finally in the bottom right to document, as we do now, whether the newborn needs hepatitis B prophylaxis due to maternal carriage, but also HIV prophylaxis for the infant of the mother who is HIV positive. Next slide, please. Thank you. This again looks very familiar. It's very similar in almost all prenatal records. We just added a few things, a column for fetal movement, a column to identify when the next visit was recommended, and then a column to put the initials of the care provider. Given that many of us are now working in teams, we have learners in our practices, and it's important to know who actually conducted the visit. At the bottom of this page, there is actually room to have like a kind of an initial key where the initials can be each person's name and initials are documented at the bottom of the page, so you know what those initials actually mean. Next slide, please. This looks very new. As Anne mentioned in her introduction, obviously prenatal genetic testing is just a moving target, and it is changing day by day, week by week. So this is our best effort at this time, but we fully expect that this will change again. So some of the things that we did to improve, what we hope improve this section, first of all, putting it on the second page, because much of that happens in the late first and the second trimester. Currently it's on the first page, so you have to go back to document. And we also really specified the inclusion of several different prenatal genetic tests with a guide as to the gestation when they're most appropriately done. This is, again, we really had to think, as we've been developing the form, we really want this form to be useful to all prenatal care providers. And we recognize that there's a large group of family physicians particularly who do early prenatal care and then transfer for interpartum care to obstetricians, perhaps midwives. But that this group of clinicians may need extra support. And so we thought, and genetics is an area that is difficult to keep up with, so we thought that if we made it really explicit, that would be helpful for them. And the rest of us, to be quite honest. Pardon me. You'll see let's see, what else is there? Yeah, and just under the routine genetics test, you also see the conditional screening test, so the ones that you may use in specific women. So you may use fetal cell-free DNA in a woman who's over 40 or who has an abnormal marker or who chooses to pay, for example. And then really important, and that's already in our current record, is to document if she was offered prenatal genetic screening but declined. Next slide, please. The ultrasound section has just been expanded with the reality that women are receiving more ultrasounds in prenatal care and also need room to document things like placental localization, nuchal translucency, other details, perhaps soft markers. Next slide, please. We've listed discussion topics, and again, they're already there in the current OPR, or OAR, I guess. But what we've done is we've expanded them. There are many more topics here based on feedback, and we've done a kind of a rough sorting by trimester when it might be helpful to address these topics. Again, nothing is in stone, but it's just a suggested timing to help the clinician identify maybe which topics should be addressed earlier on and which you can come to later. Next slide, please. This section doesn't look much different, and the only really addition here is second from the bottom, tests that you might want to repeat as indicated. So for the woman at risk of contracting STIs in pregnancy, you may well want to repeat her GC chlamydia and maybe even HIV more than once in the pregnancy, someone who's hypothyroid, etc. And then we've got room, and there's more lines for other tests, again, that are specific to the woman whose pregnancy care you're doing. Okay, next page, next slide. So this is a completely new page, and we're calling it the OPR Screening Tools. And this is to help clinicians use the tools that we've identified that could potentially be helpful for primarily mental health. So the first one that you see is an anxiety screening tool, and it's the Generalized Anxiety Disorder 2 scale. So it's very, very simple. It's a 2-question scale. And you can see how to score it. You just get a point, 1 or 2 or 3 points for each question, depending on how often in the previous 2 weeks the woman is bothered by those problems. The score is added up for those two, and then the cutoff is 3. And all we're doing here is suggesting that if she has 3 or more, the clinician may want to probe further, either use a better anxiety screening tool or refer on to mental health resources in the community. Next slide again. This screening tool looks very similar, but it's for depression. So it's a 2-question PHQ, Patient Health Questionnaire. And again, the STEM is the same. So these tools are easy to use together once you've sort of asked them a few times. And again, the scoring is done exactly the same way, and it's cut off 3. So if the woman is 3 or more, again, you would consider further screening. So you could use the PHQ-9, which is a more sort of fulsome screen for depression, or the Edinburgh Postnatal Depression Scale, which we've also included on this form. And again, suggesting that a woman who scores highly in that may require additional mental health follow-up. Next slide, please. This is a screen for problematic alcohol use in pregnancy, specifically in pregnancy. All women should be asked about their use of alcohol, and then again about their use of alcohol in this pregnancy. And if they endorse that they are drinking in the pregnancy, this is a helpful tool that sort of quantifies a bit how concerned you might be about the woman. And it's one of the screening tools that is endorsed by or recommended by the SOGC guidelines for alcohol in pregnancy. Next slide. And finally, on the screening tools page, we include the Edinburgh Perinatal or Postnatal Depression Scale. So it's been validated for both depression in pregnancy and postpartum, well-used, well-validated tool. But we felt that really the clinicians would be more comfortable using really short and easy-to-use tools, and then use the EPDs really as a backup test. And I think most of us certainly have familiarity with it. And I think it's important to have it just so that you can use it as a backup test if you identify depression in pregnancy, or as a screening test in the postpartum period as well. And the next slide just shows the scoring of the EPDs. And the one thing I just want to point out was that with the EPDs, item 10 is a question about suicidality or self-harm. And again, that's the one question that we identified that if there's a positive response of any score in that question, the patient requires immediate mental health follow-up. Next slide, please. Okay. And finally, we get to the postpartum visit. And again, here we just include more details about the birth, and also more psychosocial details, and we follow up on the immunization questions that were raised in the second page of the prenatal form. You look at that for a sec. And next slide, please. Again, we include a number of discussion topics. We've made it a bit more comprehensive, including things such as future mode of delivery, like starting that conversation for the woman who's had a cesarean section in this birth, and starting the conversation right at the postpartum visit. Well, you know, are you a candidate for a VBAC next time? Should you choose that? What is the ideal spacing for pregnancies if the woman has had a C-section? That kind of thing. And again, just to cue clinicians as to what is helpful. Next slide. So what's missing should be like a test. So what do you notice we don't have? The symphysis fundal height graph, after much discussion, and we've had some feedback about it, mostly good, but some, I missed the graph. People really told us to describe that they weren't using it. That's number one. There is, however, some evidence that population-specific graphs actually might increase the detection of IUGR. But we could not obtain those graphs for use in the Ontario Perinatal Record. So I think this is actually emerging research And we may have to revisit this in the future. But at this point, particularly people who are using EMRs, where there's no functionality for the graph, we're not using it at all, and so it's just using up space. We also don't have any kind of formal risk stratification. This is something we do clinically all the time, but there's actually no evidence that a formal scoring system works or improves outcome for women because risk is fluid, and it's really part of our professional judgment, and doing one risk assessment at one point in pregnancy is really not helpful. Next slide, please. And Anne mentioned that we were writing a user guide as a new resource to really clarify how to complete each data point. Also to connect readers to the guidelines to care, really to help clinicians. But I have to say there's real tension, and it's hard to get it right, because there's tension between simply writing a guide to say how to fill out the form, which is useful in itself, especially when it's a new form. But also, so that would be sort of the bare minimum. But then there's also this kind of, we have this desire to write, the most comprehensive book about everything you could ever ask about prenatal care, which of course is not A, our mandate, or B, really desired in this project. So we're tending more towards the former, with really trying to be complete about how to fill in the form, and a resource, sending people to resources that may help their clinical questions. Maybe a little bit, we have some details about how to ask questions, especially the tricky ones, such as intimate partner violence. And the next slide will take us back to Anne Sprague.
Right. So I wanted to put a little plug in for this as we're going through it, because you saw the sort of large list of discussion topics from each trimester of pregnancy, but also then in the postpartum period. And luckily, at the same time, we've been working hand in hand in doing the Ontario Perinatal Record. A group in Bourne has also been developing OMAMA, and OMAMA recently went live, which is a wonderful new resource built for women and families about care during, in the prenatal period, the pregnancy period, and the early child period. So I wanted to put and just give a plug for that this will be a great resource for care providers to recommend to women to answer some of those very, very common questions, and it is Ontario specific. Next slide, please. And so you can go to omama.com. There's also an app to download that women can have a little bit more interactivity and functionality in terms of reminders about important milestones. So that's a good complement, and hopefully you'll be recommending that to the women that you work with. Next slide, please. And so just to finish up, talking a little bit about some of the challenges that we face doing this project, it's incredibly time-consuming. And in fact, we don't feel so bad because the last record took 5 years to update. But, I mean, there's just been the process of not only doing this part, which is just getting it right from the evidence and from what people told us was important, but also now having to develop a user guide. And then the third part is building the functionality for an EMR. And so that, that will be like a part 3 of a project. There have been many stakeholders involved and many differing opinions, and we've had some pretty good discussions sitting around tables. And I have to say, one of the more amusing parts of this project is the fact that both of the co-chairs have the same name, Anne, and then Anna works at PCMCH with us, and you can imagine what it's like on a conference call when it's like you go to identify it's Anne here or it's Anne here, and so it's been quite funny going through that process with everybody with the same name. It has been a challenge of convening busy clinicians for full-day meetings. Everybody works as volunteers on this project, and they all, everybody has their day job, and getting time to do this has been challenging, but we soldiered on. And then, the challenge will be having a staggered implementation. If you had a new record, ultimately you'd like to all go live and everybody using the same version at the same time, but with EMRs, it's just not going to be possible to do that because of, various providers introducing new versions at different points in time. Next slide. So what is happening with the EMR version? As I mentioned, we are talking about functionality now. We've had, good feedback from people who have used the pilot project that we did a couple of years ago. We are working with 3 vendors to start with, and they have a large market share in Ontario of people who will be able to use this. So that's Oscar, QHR Accuro, and TELUS. And if you are in an office and you want this new form, be sure to lobby your EMR vendor, because it's only by your lobbying that they'll bring it in to use quicker. That said, it's not quite done yet, but when we get there, we'll let you know more about that. Next slide. So our next steps are graphic design and formatting for the paper version, working on the functionality for EMR, completing the user guide, as I mentioned. We're right now incorporating the feedback, as I mentioned earlier. We've got multiple comments from people, mainly about size and legibility of the record. You can imagine it was already crowded, and there's a little bit more stuff in there. So we are, making serious consideration about a 3-page record. That said, that's difficult for a lot of people to think about. I mean, we're also hearing, a lot of comments from care providers about adding substantial information about mental health screening and stuff into an already very busy appointment. So, we're trying very much to, listen to those comments and yet provide the best evidence-based care that we can. We will need to do pilot testing of this when we're completed, and then we have to plan for the wider implementation across the province. Next slide, please. So that's really the end of our formal presentation, and Kathy, I think you want to facilitate questions and remind people that there's both Anne and Anna on the line to answer your questions.
That's right, both Annes and Anna. So as Anne said, if you have any questions, please type them in the chat box located on the bottom left of your screen there, and we'll be happy to answer them. So I see a few now. The first one is, are you able to talk about research surrounding dipping urine for protein?
I guess it's Ann B. I guess I should take that one, although I don't think I can really speak to the research. But there was consensus that it would stay in the record, although I know that's controversial.
Thank you, Anne. Another question, is there a section in the record to discuss recent travel?
That's a good question, and I don't think that we have anything specific. Anne S., can you think?
No, there is a section on infectious disease and exposures, a little bit, but not specifically related to travel. And that's really pertinent this week, when you're hearing all this stuff about this virus in South America. And so that, Anna, that might be a good thing for us to consider and note.
Yeah, so I was going to say we will be shameless about taking suggestions and feedback back to the group from this presentation, because as you see, it's not finalized at all. So thank you for great suggestions.
This is Anna, and I'm taking notes.
Oh, you got them. Wonderful, Anna. Thank you.
Another question, a comment, looks great, but the absence of Healthy Babies, Healthy Children referral, both in the discussion topics as well as on the postpartum form, is discouraging. Any talk of adding a spot for Healthy Baby, Healthy Children referral?
Yes, absolutely. We've gone through about half of the stakeholder feedback with the group, and on the list of discussions is absolutely that, linkage with Healthy Babies, Healthy Children. In fact, we got very good feedback kind of lining up the question items that are in the Healthy Babies, Healthy Children screen that are not in the OPR. We cannot promise we'll get them all into the OPR, but I think some linkage will almost certainly be a result of our next set of discussions.
Thank you, Anne. Sorry, keep your questions coming. It's bouncing around my box a little, but that's okay. What did the question box saying presentation outside of gestational window mean?
Oh, that was for, yeah, sorry, it's Ann asked. That was for women who show up to prenatal care too late to have prenatal screening. And so it was just an indication that before that was never recorded. And so it was just to indicate that, I believe. Right, Ann?
Yeah, exactly. So, I mean, there are a couple of reasons why she might not have been screened. We want to make sure that everybody is offered screening, but if she's too late, so if she presents for her first visit at 24 weeks, she's too late for any of those markers.
Thank you. Any thought given to screening for breastfeeding self-efficacy? Sorry.
We not in terms of screening. We have Matuszka Sheedy is part of our group, who is very knowledgeable of breastfeeding, and as a result, we certainly have the history of whether the infants were breastfed with a previous pregnancy, and questions in the counseling topics in a couple of trimesters at least, and then in postpartum again. But not using that particular tool.
Thank you, Anne. The OPR did not come back to the section of public health physicians at the OMA. Is there still time?
I would think, Anna, you have to, I mean, we're going to have to go out again with a sort of a mock-up of a potential 3-pager just to see what the what the response is. We certainly did get public health response, but maybe not from the OMA section of public health. So we can certainly talk with Dara Laxer, who is our policy contact at the OMA. And if you would like to have input, I think that can be arranged. Anna, do you think so?
Absolutely, yeah.
Yeah.
Great. Any information on obesity, an important criteria in cesarean section?
So it's Ann Sprague here. We are capturing BMI on here, and in the guide, there will be, a section on talking to women about healthy, active living and that sort of thing. But I understand the concern specifically related to C-section and other interventions. Ann, do you have anything to add?
Yeah, we haven't added anything anymore. Just the BMI and the counseling topic around obesity and ideal weight gain and physical activity, and then in the guide. So that's about all we've got there. I mean, clearly a risk factor that's very, very common. It's really one of those things that we get so many great suggestions that we know are part of our regular care, and just how much can we get into the form before people completely revolt.
Yeah.
Okay, lots of questions here. Just bear with me here till I get to the bottom of our last one. Do you think omama.com should include alerts for urgent, timely, volatile maternity care issues, such as the Zika virus? I know it's in the news. I'm not pronouncing that properly. What do you think? It says contact me at omamaproject@gmail.com with ideas. So that'd be from Wendy Catherine.
Yeah. So people should feel free to respond to Wendy about that for sure.
Supporting Healthy Baby, Healthy Children comment. Public health units hoping to start interventions prenatally. Therefore, the need for prenatal referrals from primary care providers will be important.
Yep, and so we will follow up on that.
What about screening for poverty? Is there a poverty tool developed by the CFEP?
In the guide, we include a poverty question. It goes something like, do you ever have problems making ends meet, or something like that we include so that people can. It's a quick and easy question regarding poverty. It didn't make it onto the form, but it's in the guide.
Okay.
Can I ask questions? Because I see a couple of questions coming up on the screen as well. Do they go to you as well?
Mm-hmm.
Okay.
Yep, I'll read you those now.
Okay, I don't want to rush you. No, I just...
No, that's okay. And all attendees can't see these questions. So recommended time in pregnancy for, is it Tdap? I know it's a vaccine if due. Their guidelines, the NACI, the National Advisory Committee on Immunization, has guidelines which, interestingly, are different than the guidelines of the American guidelines, CDC. So if she's due, you can actually give it any time if she's due. Some women want to wait till postpartum, but you can immunize pregnant women if it's been more than 10 years. If there's an outbreak, chances are they will actually recommend vaccinating women in the third trimester. But at this point, there's no active recommendation for vaccinating by the Canadian guidelines in the absence of an outbreak. Whereas CDC in the States, they're recommending actually boosting every pregnant woman in every pregnancy with Tdap. So it's quite a difference in care. Wow, thank you. Another question, the mother donor and father donor lines in the genetic screening section are not gender inclusive and do not capture all permutations of how babies are formed. Any considerations to using egg sperm as they are more accurate and inclusive technology?
Terminology.
Anne, do you want to address that?
Well, we have had this discussion a lot, and B often talks about, you just couldn't put this word on the form, but what's the word, Anne? The progenitor?
Progenitor, yeah.
Yeah.
So, we've had lots of feedback about that, and we actually are, that is on our list of discussion with the committee, and it will most likely get down to, egg and sperm. We're having real problems with completely inclusive language, and can I give you an example? So just sort of to be kind of frank. After years and years of practice, I think most of us identify the pregnant person as the woman, and we call it woman-centered care, and we want to call her a woman as opposed to a patient or as a whatever else. However, that is actually not gender inclusive, considering maybe transgendered. And so now we're getting pushed to actually go back to patient and client, which really seems like a funny step back, to be honest, but is more inclusive. So we're learning a lot, and we're having some great consultation with people that know a lot more about gender inclusive language than we do. So that absolute comment about egg and sperm has come up, will be discussed further, is likely to be changed, and has already had a discussion. We already have written that section in the guide, which identifies this whole business of many different permutations and combinations for making a baby and making a family.
Yeah.
Thank you. Can you comment on number 5 you used for binge drinking? We are under the impression that binge drinking for women is 4 or more drinks at one time.
We took the tool right from the literature, but we can definitely check it again.
Yeah, we'll go back and check that. I know that our experts have seen this version of the form, but happy to go back and check, absolutely. Because that would be a bad mistake to make.
Great. Another question here, additional resources for healthcare providers and to refer clients to, please consider the soon-to-be-released Best Start Resource Center, prenatal key messages, CEP preconception tool for interconception care, as well as others. Could these be added as reminders?
We already have the CEP preconception tool referenced in the guide, and in the electronic form, in version, it'll be much easier to link to resources. One of the problems you have to remember, though, is that links to web pages and websites become stale, and somebody will have to take responsibility for updating them. So we'll probably reference resources rather than actual sites.
Yeah.
Thank you. Can you comment on the 3 or more score you used for the PHQ-2 score? We are under the impression that a score of 2 or more is more sensitive and may identify more women.
Absolutely true. The lower score you get, you identify more, but of course you also have more false positives. And so it's more sensitive but less specific. And so we got this from the literature, but we're going to take one last look at it by Dr. Tadili Dennis and our mental health specialist, just to make sure. Because to be honest, the PHQ was recently put into the form. We had the Woolley, which is also a 2-item depression scale. When we had a second look at that tool compared to the PHQ-2, we felt that it matched the GAD-2 better, and so it would be just easier for clinicians to ask. They're really mirror images of each other. So I will check on the score, but I'm pretty sure that, because I actually did look at some of the data, that 2 would be identifying too many people, and we don't want to flood the mental health system with women who don't need it. On the other hand, you're right, we don't want to miss women who need the services.
Thank you, Anne. No new questions in the chat box, but we still have 5 minutes. Maybe while we're just waiting, I will let you know that our next scheduled Bourne Provincial Rounds is March 24th. Our speaker is Dr. Aileen Hutton. Dr. Hutton is an assistant dean in the Faculty of Health Sciences Midwifery at McMaster University. She'll be discussing her recently published paper looking at outcomes associated with planned place of birth in Ontario among women with low-risk pregnancies. So stay tuned for the usual Bourne announcement regarding our next rounds in March. Let me just have a look at our chat box again. Wondering about the Q, re how many drinks it takes to feel high. The word high is usually associated with drug use.
Yeah.
Go ahead.
Sorry, go ahead. That's true. That is a standard tool that's been in place. So we can look about whether or not there's a modification of that tool at all in the literature, but it is a standardized screening tool.
Yeah.
Thank you, Anne. Can an option to decline be offered on the screening tools for depression?
I think that any woman has the right to decline any part of prenatal care, questioning, whatever. I think our feeling, though, is with mental health screening, just as with the other, let's say, blood test screening, we want to push clinicians a little bit to sort of opt in, so that the standard of care, or the baseline is to ask. But you always preface that kind of question with something saying like, mental health issues are really common in pregnancy. A lot of women feel depressed or anxious, and as a result, I tend to routinely ask all my patients these, questions about that. Is that okay with you? Currently, I use a different form of screening. I use the alpha form in my pregnant population, and again, I've actually never had anyone decline. They get to look at the form. They can, tear it up if they want. But I find that really women are incredibly receptive to the thought that we actually care about their mental health, not just their physical health.
I think there's also the important point, and care providers brought this up when we presented this at the SOGC meeting in early December in Toronto, and that, you may also, these tools are also meant for women to do on their own as well. They can be done that way. So if in an office you have people sitting there waiting to see you, there's no reason why a screening tool couldn't be done and then discussed, at the visit. So it doesn't rely totally on the care provider, but it may be that, it may be a conversation that occurs based on a screening tool that's filled out.
Yeah. And in fact, just to plug some research that my colleague Dawn Kingston and I in a big group did in looking at women's response to different ways of screening for mental health issues. Women were very receptive to using, a paper form and a clipboard in the waiting room, using a computer, taking things home and doing them at home. They were very receptive to their primary health care provider asking about that in the visit. What they really weren't that comfortable with was raising the questions themselves unprompted. So these tools are really opening the door to conversation.
That's great. I think we have time maybe for one last question. It's 12:59. Maternal, paternal age. Is there consideration of adding maternal, paternal age? Is this a component of the tool?
It's on the form, the maternal age at delivery and the partner's age.
Great.
Under demographics, it's there. Yeah, just disguised with all the other words.
So that brings us to 1 o'clock and the end of our presentation. I just want to give a big thank you to Anne and Anne for an excellent presentation. Just want to let everybody know you were lucky to get a seat because we actually reached maximum capacity today, and some people could not log on to the webinar because all the seats were taken. So dial in early next time in March. So thank you again to our presenters, and thank you for your attention.
Thank you.
Thank you so much for having us. Bye-bye.
Bye for now.